The gait cycle is the sequence of motions occurring between two consecutive initial contacts of the same foot. TT consists of a stance phase comprising 60% of the cycle and a swing phase comprising 40%. Clinicians must observe double support periods which occur for 10% of the cycle at the start and end of the stance phase. Assessment requires monitoring body posture, movement regularity, the position of the arms during the walk. Pyramidal or hemiplegic gait typically results from UMN lesions causing a characteristic extension of the affected leg. This leads to circumduction at the hip and an arm that is adducted and flexed at the elbow and wrist. In cases of paraparesis, both legs swing slowly from the hips in extension and are stiffly dragged. This is often described as walking in mud and indicates bilateral pyramidal tract involvement. Foot drop or a high-stepping gait is caused by LMN lesions affecting ankle dorsiflexion. Weakness in the dorsiflexors leads to a slapping noise as the foot hits the ground, often due to CPN palsy. Myopathic or waddling gait occurs when proximal lower limb muscle weakness prevents adequate hip abduction. The pelvis is poorly supported, causing the trunk to sway in an exaggerated waddle, seen in muscular dystrophy. The Trendelenburg sign is a critical indicator where the pelvis drops when lifting the leg opposite to the weak gluteus medius. This is common in conditions like polio or congenital coxa vara. Ataxic gait from cerebellar or vestibular lesions is characterized by an unstable, broad-based walk. Patients often reel in various directions and find it difficult to perform tandem walking. Apraxic gait involves a loss of the motor organization required for walking despite normal power and cerebellar function. The feet often appear stuck to the floor, frequently caused by diffuse frontal lobe disease or NPH. Extrapyramidal or Parkinsonian gait is marked by a stooped posture and a narrow-based shuffle. Patients exhibit festination, which is a hurried pace with short steps and may experience freezing in doorways. Sensory ataxia results from a loss of proprioception in the posterior columns, leading to a high-stepping, stamping gait. Symptoms worsen in the dark and are identified by a positive Romberg's test. Scissoring gait is classically seen in cerebral palsy due to bilateral spasticity. The thighs and knees touch or cross each other during the swing phase, creating a narrow, overlapping path. Choreiform or hyperkinetic gait displays irregular, jerky, and involuntary movements in all extremities. These movements are often accentuated by the act of walking itself, as seen in Huntington's disease. Antalgic gait is a painful adaptation characterized by a decreased duration of the stance phase on the affected limb. In hip pain, acoxalgic gait causes the trunk to lurch toward the painful side to reduce joint force. Systematic analysis of gait speed, base width, and movement fluidity is essential for neurological localization. Identifying patterns like marqué a petits pas or kinesia paradoxa provides vital clues for differential diagnosis.